Complications. Well, if pneumonia wasn't already a presenting problem, it's likely to become one. Nosocomials means happens in the hospital. Ventilator-associated pneumonias will occur in 60 to 70% of patients who have adult respiratory distress syndrome. You know, there are strategies that we use to try to prevent nosocomial infections. There's bundles, various bundles. The bundles generally include things like increasing the head of the bed, chlorhexidine mouth care, Q4 hours. That's thorough, going all the way back into the oral pharynx with chlorhexidine. We want to do sedation vacations on anybody who's on a ventilator, trying to see if they could possibly be ready for extubation. GI prophylaxis, so there's not, so that we lower the risk of aspirating gastric acids. And then DVT prophylaxis generally gets thrown in there too, but that doesn't prevent a nosocomial infection. It just tends to be part of the bundle. Infection control measures, you know, hand hygiene, foam in, foam out. There are protocols for how the ventilator circuitry has to be maintained so that consolidations of moisture in the tubing needs to drain down and not into the patient. Drain tubings before you turn the patient on a ventilator so that all that stuff doesn't run into the ET tube into their lungs. Keep the head of the bed elevated 30 to 45 degrees to prevent aspiration. Those are various things that we can do to prevent nosocomials. Barotrauma, that happens when the alveoli are ruptured during mechanical ventilation. It happens because of increasing pressures and overdistension. So to avoid, you may find that the patient will be ventilated with smaller tidal volumes, faster rates. The PCO2 might be a little higher than would be normal. We call that a permissive hypercapnia. So, you know, as long as their pH is close to normal, we'll let their PCO2 go a little bit elevated rather than blowing out their alveoli with high pressures and high volumes. Stress ulcers. They occur in 30% of patients with ARDS on positive pressure ventilation. So the management strategies there include prophylactic anti-ulcer agents, early initiation of enteral feedings to help prevent mucosal damage. And then renal failure happens when renal tissue doesn't get enough oxygen from the low blood pressure, from the low oxygen in the blood. So it's a consequence of the total picture of tissue hypoxia. It's not uncommon at all for ARDS patients. We've got them on a ventilator, we've got them on positive pressure ventilation, and we're still hovering with SATs in the 80s, and we've maxed out our interventions. So then you pray and you hope that what you're doing is enough for them to get through it. But the result is total body hypoxia. Yes, we sedate the daylights out of them because the hypoxia is going to produce confusion, anxiety, restlessness. All that costs more oxygen. And so really, you know, one of our big concerns in the ARDS patient is what will their neural status be if they recover. You know, many of them do recover and recover well. Some of them are, you know, left with some residual global hypoxic central nervous system problems. Some other reasons for the renal failure. Sometimes we use medications to treat ARDS, or we treat the infections associated with the ARDS, and those medications can be renal toxic. Nursing diagnoses. Again, impaired gas exchange is the biggest one here. Others, airway clearance, breathing pattern, fluid volume, anxiety. I mean, it's the same as respiratory failure. It really is. All right, with oxygen. They're going to need a high flow system to maintain oxygen delivery. We're going to monitor SATs continuously. We want the lowest concentration that results in a PaO2 of 60 or greater. Sometimes that's 100% oxygen. There's a problem with 100% oxygen because oxygen toxicity can produce deleterious effects. Risk for oxygen toxicity increases when oxygen exceeds 60% for more than 48 hours. ARDS patients will need to be intubated because we cannot maintain adequate oxygen levels any other way, and even when they're intubated, we're struggling. So we try to get them down. We get them down when we can, if we can, but we have to have oxygen first. Mechanical ventilation is necessary to maintain our goal. PEEP, 5 minimum. Usually we need more. 10 to 15 centimeters of PEEP. Positive end expiratory pressure. Positive end expiratory pressure to help open those collapsed alveolus. And also the PEEP helps push the oxygen through all that stuff. Additional pressures from PEEP can compromise the venous return to the right side of the heart because you're changing intrathoracic pressures. The pressure decreases venous return to the right side of the heart by decreasing preload. That can then decrease your preload, your cardiac output, and your blood pressure. So we may have to support the patient with fluids or inotropes. You know, it's not always a this, then that, then that, then that. A lot of times all this stuff is happening at once. The patient is hypoxic, they're hypotensive, they've got low cardiac output because they're hypoxic. We've got them on a ventilator, we've maximized their oxygen and their ventilatory pressures. We may have to put them on pressors, you know, levofed, to maintain their blood pressure because they're hypotensive, because they're hypoxic. They may need dobutamine because their heart's not pumping well because it's hypoxic. It's really quite a little cat chasing its tail kind of a scenario. Some positioning strategies that may be used. Prone positioning. Some places do prone positioning. I've not seen it used. Maybe I've seen it used once or twice. But what prone positioning does is it moves the mediastinal contents off of the lungs. Okay, when you flip the patient over, the heart kind of falls forward and off the lungs, and then it causes the air-filled, less atelectic lungs to be dependent. That may actually improve a VQ mismatch. You know, if a patient's flat on their back, even on their back with their head of the bed elevated 30 degrees, the ARDS, the flow of fluids, it tends to be dependent, and so the upper layer of lung tends to be the most preserved lung, or so it's thought. So when you flip them prone, you've got your most preserved lung down low, you've got the heart off of it, air is moving, air normally rises, but it can't go up into lung that's all clogged up. So the air goes to where the lung tissue is most viable, but the perfusion drops. I don't mean it goes down, I mean it by gravity. The perfusion now is perfusing. If I'm prone like this part's down, my front part's down, the blood flow goes now down, where hopefully it can pick up better oxygen. What you see, if prone positioning works, you see an improvement in PaO2 and SaO2 with the same oxygen. It may not be remarkable improvement. It may only be 5 or 10 millimeters of mercury, but that may be enough that you can come down on some of that pressure, or you can come down a little bit on some of that oxygen. Continuous lateral rotation therapy simulates postural drainage. It's a bed that just moves side to side, and it helps mobilize secretions.